This is Stephen Yakubov talking about TAVR mispositions for CVI 2020. I am the John H. McConnell Chair of Advanced Structural Heart Disease. I'm the System Chief for Coronary Intervention and Structural Heart Disease at Ohio Health Riverside Methodist Hospital and the Medical Director of Cardiovascular Research at the Ohio Health Research Foundation. Here are my disclosures. I'm going to present a series of cases to demonstrate what can happen during TAVR that puts the valve in the wrong place. Here's the first presentation. This is a 68-year-old man with a prior history of bypass on 2 occasions with multiple stents. His STS is 5% for a third-time reoperation. He has progressive dyspnea, and he's evaluated by the heart team, and surgery was offered, but he refused surgery. His problem is moderately severe aortic insufficiency as well as moderate aortic stenosis. He started to have left ventricular dilatation and a decrease in his left ventricular function. More of his problems occur on the CT angiogram. He has very little calcium in the left ventricular outflow tract as well as the aortic annulus. The annulus isn't oversized, however, the calcification or lack thereof is a big problem. His coronary sinuses are very generous. There, again, was very little or no calcium at the annular level. His iliac vessels and femoral arteries were generous. That was not a problem. So what do we do? TAVR versus SAVR? You already turned down SAVR. What valve should we use? The problems are very little calcification. And he had more aortic insufficiency than he did aortic stenosis. A 29 sapien valve was chosen as his deployment. You can see on the right the valve is being deployed, and then a PVC occurs and moves the valve up. So the pigtail catheter is in the non-coronary cusp, marking the lowest cusp on this angle, and the valve appears to be above the aortic annulus. The patient was stable. His blood pressure was fine. There was not a huge diastolic difference. The aortic insufficiency on a quick echo was not profound. An angiogram was performed. No significant aortic insufficiency was found. So what will we do now? The valve does not look fully deployed. Should we pull the valve back and start over? Should we post-dilate? We elected to post-dilate this valve. We were very careful, paced the heart very fast to stop the heart in order to try not to let the valve move. The valve was post-dilated successfully with most of the balloon in the ventricle rather than the aorta. There was excellent expansion of the valve. The valve foreshortened. There was no aortic insufficiency seen. Coronary arteries were widely patent. The aortogram at the end of the case showed that there was no aortic insufficiency and an excellent result was obtained. So post-dilatation of a valve that is secure in the leaflets near the annulus can be satisfactory, especially for a condition such as this. The next case is a 76-year-old woman with severe chronic obstructive pulmonary disease. She is morbidly obese and has been on anticoagulation for the past 5 years. Due to chronic atrial fibrillation. She had TAVR 5 years ago because she was high risk. Alternative access was used at that time to her morbid obesity. She's not had prior bypass, so she has no bypass grafts, and now her TAVR valve has failed. She does need surgery of an adenocarcinoma of the colon. She's had worsening gradients. She has been on anticoagulation, so the decision was made for TAVR once again. A 23 millimeter sapien valve was chosen. She has a prior evolute valve. We elected to protect the coronary arteries since the leaflets of the evolute valve will extend above the coronary arteries after the second valve is put in. Fortunately, the posts aren't over the coronary arteries. This is demonstrated by angiography prior to the procedure. We elected to protect both the left and the right coronary arteries. Here a guide catheter is introduced to the evolute valve. A wire is airmailed into the left main, and in the usual fashion we use a balloon and a guide liner inside the guide for coronary protection. The image on the right shows that still frame. The next image shows the right coronary artery being done in real time. The guide is near the coronary artery. The wire is passed into the coronary artery, and then a guide liner and balloon are then passed. So we have protection of both coronary arteries. Even with those catheters inside the valve, the sapien valve was able to be passed easily. The guides were not moved out of place. The sapien valve is in adequate position for deployment. The sapien valve is positioned below the coronary artery. During deployment, this was under conscious sedation. She became excessively anxious at the time that pacing was done. She started thrashing around very quickly, taking large deep breaths and moving on the table, which made the valve positioning quite a challenge. Finally, the valve was deployed. It appears to be low. The gradient was somewhat high, so post-dilatation was performed. Her mean gradient was 22 millimeters. She did not have aortic insufficiency. And you could see with a 23 millimeter true balloon, the sapien valve was then anchored very securely against the evolute valve, and there was foreshortening that occurred of the sapien valve. The final angiographic result was very satisfactory: trivial aortic insufficiency, widely patent coronary arteries, and an excellent result by echocardiography with no PVL seen. The gradients were only 6 millimeters by echo in the room, 6 millimeters by echo the following day. The next presentation is a 71-year-old man with severe aortic stenosis. And this also shows that things don't always go as planned. This is a sapien valve being placed in the aortic annulus. The pigtail again is in the non-coronary cusp. Everything's going along just fine with valve deployment until a PVC occurs. And this occurred even with full balloon expansion, almost toward the end of the balloon expansion, and it moved all the way out of the annulus. In this particular instance, we elected to blow the balloon up, drag the valve back. It was dragged to the ascending aorta, and then finally dragged back beyond the left subclavian artery. Another sapien valve was then passed. Here is the image of the other sapien valve now being placed. A little faster pacer rate, a little quicker balloon. An excellent result was obtained. So in conclusion, the valve misplacements can occur for many reasons, and you have to be prepared for the unexpected. Be prepared to handle any variation in misplacement. Thank you.